Good afternoon, everyone. Thank you for joining us for Grand Rounds today. We have a very special guest who's here today, Dr. Saira Khaderi. She is a actual U of H graduate, so a Coug and alum of the university. She received her undergraduate degree in biology here at the University of Houston and went on to pursue her medical degree at the University of Texas Medical Branch in Galveston. She also received her master's in public health at UT School of Public Health here in Houston, completed her internal medicine residency at Cleveland Clinic Foundation, and went on to pursue and complete her fellowship in transplant hepatology at the Baylor College of Medicine. She is joining us as a specialist in transplant hepatology and in viral hepatitis. She is the medical director for Project ECHO, which stands for Extension for Community Healthcare Outcomes at Baylor St. Luke's Medical Center. Project ECHO uses video conferencing to develop expert healthcare networks to manage complex liver diseases in underserved areas. This project over the past 10 years has treated over 2,800 patients for hepatitis C and hepatitis B across the United States, most of whom are uninsured. This is her passion and her life's work, and we would like to welcome her as she comes to speak to us about hepatitis C in the setting of primary care. Please welcome our speaker.
Hi, everyone. Thank you so much for the invitation. I've already told several people today, I am very excited about being here. One is because it's sort of a homecoming for me because I graduated from the University of Houston, sad to say last century, but still, I did my undergraduate degree here. And another important thing, I've been a specialist for about 10 or 11 years, but the most favorite part of my work is working with primary care physicians and clinicians to treat hepatitis C. And so when I heard about the medical school here and the program, I feel like it's a wonderful, unique program and so important, as you'll see about what I'm going to talk about. My disclosure, I did some, I think, advisor for AstraZeneca with the liver cancer medication. So the objectives for today, we'll talk about the fundamentals of hep C diagnosis. We'll talk about hepatitis C in the United States. I'll go over the different treatment regimens we use to treat hepatitis C. And really, I think one of the more important parts of this talk is hep C elimination and the role of primary care. So I will be the first to say that I underestimated the functions of the liver when I was in med school. You know, the heart and the kidneys, they kind of stole all the attention and the liver was sort of just there. But the liver does have many functions. It helps detoxify, it helps with metabolism, it makes proteins, bile, blood sugar balance, all of that stuff. And it is actually very crucial to everybody. And the biggest thing, which I probably maybe didn't realize, is without a functioning liver, you don't live, you die. So this is a normal healthy liver. Most of us are born with a healthy liver, but there are many things that can cause damage to the liver. And over time, usually not in a period of 5 or even 10 years, but 20, 30 years, if you have something that's damaging the liver, you can end up with cirrhosis. And cirrhosis is when the entire liver is scarred. Most people with cirrhosis don't actually know they have it because they may not initially have symptoms. But as time goes on, they can get sicker. And about a third of patients with cirrhosis will develop some decompensation. And so I think many of us will think of ascites, variceal bleeds, liver cancer. Anybody who has cirrhosis is at risk for liver cancer, and then really just liver failure. This patient here has jaundice. So the thing that sets the liver apart from some of the other important organs is that there is no replacement for the liver. So for a heart, you have LVADs, you have a ventilator for the lungs, and even for kidneys, you have dialysis. But again, we have nothing for the liver. So if someone's liver fails or stops working, the only option is transplant. Now, there are many different causes of liver disease, and I think people tend to focus on Hep C and alcohol, kind of the first things. But it's important to realize that there are genetic causes, there are autoimmune causes. Very common these days is steatotic liver disease, formerly known as fatty liver disease. And so patients can have diabetes, be overweight, have a little bit of high cholesterol, never drink, no tattoos, and still end up with cirrhosis. And then what we see commonly as well is that patients may have one or two more, like two or more things that can cause liver disease. So they may be a little bit overweight and they drink. So you have to keep all of this in mind when you see patients with cirrhosis, because I can't tell you the number of times I have patients with cirrhosis come up to me and say, everyone accuses me of drinking and I don't drink. So it's important to realize there are other causes. But today I am going to focus on hepatitis C. So this is the hepatitis C virus. It was discovered in the late 80s. It is a worldwide problem because, as I stated before, over time, it can lead to cirrhosis, it can lead to liver cancer. Back in the 60s, 70s, and 80s, people would contract hepatitis C either through blood transfusions, blood products, or IV drug use. These days, depending on what part of the world you're in the United States, it's still IV drug use, but in other parts of the world, third world countries, it's iatrogenic, and I'll mention that again later. But the good thing about hepatitis C is we have really good treatments and we can cure hepatitis C. So in 2013, the United States Preventative Service Task Force had given some recommendations about who we should be screening for hepatitis C. And basically, it was patients who had risk factors. And then they added the population of baby boomers, people born between 1945 to 1965. Now, you don't have to remember this because I always say maybe one of the only good things that came out of March 2020 was that they changed their recommendations. So now every adult 18 and I would say even above 79 years of old should be at least screened once for hepatitis C in their lifetime. So no more risk-based, everybody 18 or older at least once. And if someone has ongoing risk factors like continued IV drug use, then usually we recommend checking them annually. Now, half of the people in the United States who have hepatitis C don't know they have it, and that's about 2.5 million people total. So the first issue is we're not doing a good job screening. When you diagnose hepatitis C, the first test that's ordered is a screening test, and it's an antibody. If that is positive, most likely the patient has hepatitis C, but you always have to confirm it with a viral load. The viral load is what tells you they have hepatitis C. If it's negative, they don't have hepatitis C. Treatment decisions, how you decide how to treat someone with hepatitis C is really simplified. And really, you're just looking at were they treated before? Do they have complications of cirrhosis? And what other medications they're on? And again, we'll talk about that a little bit later. So hepatitis C in the United States. This was a study that was done by one of my colleagues at Baylor, and it was from 2012, but it looked at veterans from 1996 to 2006 that had hepatitis C. And you can see that over the period of 1996 to 2006, the prevalence of cirrhosis went up. So when prevalence of cirrhosis goes up, you're going to have more patients with decompensated cirrhosis, and you're going to have more patients with HCC, liver cancer. Now, why was this happening? What I told you before. At this point in time, about 75% of patients who had hepatitis C were baby boomers. And so what you saw was people who acquired hepatitis C in the 60s and 70s, 20 years later, were now developing cirrhosis and its complications. But the face of hepatitis C has changed. So this is an article that was printed in 1985. And you see it's talking about the use of opioid analgesics. So prior to this article, it was thought that opioids should be used in patients who have cancer because they're habit forming. But this was one of the first papers to say, nope, that's not true. It's safe to use opioids in people that don't have cancer. It's not addictive unless they already have maybe a psychiatric illness to start with. And then in 1994, Purdue Pharmaceuticals, the makers of oxycodone, convinced the FDA once again, these are not habit-forming medications. They can be used long-term, not an issue. Well, obviously, we know that was wrong. So this is the cover of Time magazine in 2015, where all of a sudden everyone, started waking up and realized that these medications are best short-term, they can't be used long-term. And so what happened? The physicians and the clinicians completely stopped prescribing these drugs, which obviously is not the way to do it. So then you had all these patients that had been taking these medications for very long periods of time for pain they had, and they were completely cut off with no substitute and nowhere to go. It was very hard to get a prescription now because of this crackdown. And so it was easier to find your medication on the streets, or even heroin, which was IV, which you would get intravenously, use intravenously, was even found cheaper than oxycodone on the streets. So you had these patients who were getting opioids on the streets and then also using heroin. And you can see here that this looks at the number of overdose deaths. And you can see in 2010, it was about 20,000, and it almost quadrupled by 2021. So this changed the face of hepatitis C, because we still had the baby boomers who had hepatitis C, but now you had this younger population of patients who had been using maybe IV drugs, and now they were acquiring hepatitis C. So I want to just take a few moments to talk about hepatitis C in IV drug users. There is a huge stigma about not treating these patients. And so often direct acting antivirals, those are the medications I'm going to talk about later today, is restricted. And I have colleagues myself who will say, no, if the patient is using IV drugs, we don't treat them. But that is absolutely false. All the guidelines, the American Association for the Study of Liver Disease, the infectious disease groups, they all support treating these patients. And the reason for that is because there is actually no difference in adherence. These patients who are ongoing IV drug users take their medications, they take their hepatitis C medications just as well as the patients who are not. There is no difference in SVR. So SVR is sustained virologic response, which is cure. So patients who are IV drug users get cured just as much as those who are not as well. There is actually a low risk of reinfection. I hear this often where people will say, why am I going to treat them? They're just going to go out there and get reinfected. But the risk is actually pretty low. The studies have shown it's less than 5%. And even if you think somebody's going to end up getting hepatitis C again, you can treat as prevention, which means that at least the time that they are treated and cured of hepatitis C, they're not going to pass it to others. So this is very important to understand that IV drug users or patients who have had any of these issues should be treated for hepatitis C. The other issue is there's a huge ethnic disparity in hepatitis C, as many other things as well. So this looks at the rate of hepatitis C based on demographics. And unfortunately, the American Indian and the Alaskan Native are always at the top because of their lack of access to care and treatment just in general. But the people that are acquiring hepatitis C more are the non-Hispanic whites, and then you can see the Blacks and the Hispanics. So when you look at who's getting hepatitis C, it's non-Hispanic whites, Blacks, and Hispanics. But then when you look at who's dying from hepatitis C, it's actually the Blacks and the Hispanics that are dying more than the whites. So although the white non-Hispanics get hepatitis C more, the groups that, the Blacks, the not Hispanic Blacks and the Blacks tend to die from it more. And why is that? So I feel like I'm preaching to the choir in this group because you all understand why that is. So patients who are Black and Latinos, they tend to work jobs where health insurance is not the best. And for a long period of time, you had to have really good health insurance to get these medications. They may work jobs where they make just a little bit too much to be able to get insurance, and private insurance is too expensive. Then there's Medicaid. So over half the patients on Medicaid are Latins and Hispanics and Blacks. So, right, and Medicaid has historically been the most strict with approving these hepatitis C medications. So they would order all kinds of testing. You had to have a certain number of so much scarring in the liver. They would do drug tests, and it was every patient with Medicaid we would try to get approved would get slammed and would be a no for the longest time. So again, you're disproportionately affecting these patients because the majority of these patients or the majority of Medicaid patients are underrepresented minorities. And then there are some studies that show that sometimes physicians didn't really have a good reason as to why these patients were not eligible for these medications, but they just deemed them not eligible. So for example, kidney disease was used a lot for a lot of Black patients, but kidney disease is not an issue when it comes to these hepatitis C drugs. So I think there was a lot of bias as well. Now, Hep C elimination. In 2016, the World Health Organization came up with a hepatitis elimination plan. And what they said was their definition of elimination was to reduce the cases of hepatitis by 90%, as well as reducing the number of deaths by 65%. And how would we do this? Well, one, you needed effective treatment, which is great, right? We have really great treatment that I'm going to tell you about that's easy to take with cure rates of close to 100%. But two, you also need allocation of resources. So it's great that we have these medications, but if the patients who need them can't afford them or don't have access to them, what's the point? Three was education and training. So you heard me mention that in the United States, hepatitis is really acquired through IV drug use most commonly. But in other countries around the world, like Pakistan, it's actually iatrogenic. So patients will go to the dentist or they'll go to a lab to have their blood work drawn, and the same needles are being reused, and that's how hepatitis C is being spread. Four was focusing on marginalized groups. So as a hepatologist, I have a busy clinic. I see maybe one patient with hepatitis C a month. So the patients that come to my clinic, they have insurance, they've already been treated, and many of them were treated 5+ years ago. But the people that need treatment, the people that are living with hepatitis C right now that, I guess for a lack of better terms, have been ignored are the marginalized groups. So it's focusing on getting treatment to these groups, whether it's IV drug users, other ethnic minorities. This is really who we have to focus on. And actually prisoners is another big one. And then the last thing was inclusion of primary care. So this is very important. I would tell you for 10, 11 years, I have been promoting or pushing primary care is essential in eliminating hepatitis C. These medications are easy on the patients. They're easy. They don't require much monitoring for treatment, and they're very, very effective. You do not need to see a specialist to get treated for your hepatitis C. So this is Dr. Francis Collins. He used to lead the NIH, and he has been the leader in President Biden's national initiative on Hep C elimination. So the World Health Organization, like I said, had started this in 2016, but as we all know, COVID happened, and so things were put on pause. But last year, there was more motivation to get this plan going, and so there are many facets to this different plan. One is point of care diagnostic test. So I told you before, the way that someone gets diagnosed is they come in for an antibody test, then they go home, then they have to come back for the viral test, then they go home, and there's multiple steps. So wouldn't it be great if a patient could come in, have one test done that says they have hepatitis C, it's confirmed, and they walk out with their medication? That would be perfect. And it does happen in other countries as well. So it also said we need to broaden access to these hepatitis C drugs. Again, instead of patients coming to us, we need to go to the patients in their communities, in their clinics. And again, a lot of these are the marginalized groups. A third thing was a national subscription model. So this was used in Louisiana and was very successful. And basically the government paid a certain amount to Medicaid to have patients treated, sort of like you pay for your Netflix subscription, but you can watch as many movies as you want. And with that money, they were able to treat all the Medicaid patients, no restrictions, as well as prisoners. And the idea is to have something like this as more of a national plan. And then there were other parts to implementation, screening. I told you before, half the patients with hepatitis C in the United States don't even know they have it. Expanding the providers. Primary care is critical to treating and eliminating hepatitis C. Expanding community health workers. So a lot of these patients, especially the ones that go to Suboxone clinics and so forth, it would be great if they had patient navigators that would call them to say, hey, did you come back to get your testing done? Have you come in for your prescription? Navigators make a huge difference in making sure treatment is completed. And then re-energizing vaccine research and prevention. So there's no vaccine for hepatitis C, but they are working on it. So this is the cascade of care that seems to cause a lot of trouble. So if you look at all the people that have hepatitis C, only 50% are aware that they have it. So they have to have that antibody testing. And then only another 20% actually come back for their RNA testing. And for those that would come back, then even less would actually get linked to Hep C provider, get their medications, and then complete the treatment and get cured. But again, what if all of this could be done in one step? And that I truly believe that it can, if we can get that point of care testing done. Because as you see, every next step is where you lose more and more patients. All right, so Hep C treatment. So this is the timeline. So I told you hepatitis C was diagnosed or was discovered in the late 80s, and quite honestly, it rode the coattails of HIV because that's about the time that HIV was in the news. And so because of HIV, the blood products, the blood supply, all of that started to get tested for hepatitis C as well as HIV. So for those who are old enough to remember, we used to have awful drugs for hepatitis C called interferon and ribavirin. And these medications the patients, most of them would have to take them for a year. They would cause thrombocytopenia, they would cause anemia, they would cause suicidal ideation. And they were very, very difficult to take and a lot of monitoring. And the sad part was, even in patients who took it for a year, only about 40% ended up cured. And if you had cirrhosis, it was closer to 20%. But then in 2011, we began to have some better medications coming through, approved. But really 2014 is really when we had the all oral medications that work very well. And I put my picture in here because this is when I started in hepatology in 2010. And my first day at work, I treated someone with interferon and ribavirin, but fortunately that wasn't for too long. So I was able to get the experience with interferon and ribavirin, and I've been able to see how far we've come in just a period of 10, 12 years. So I show this chart just to explain a little bit about the antibodies. So when someone acquires hepatitis C, when you check the antibody, it can sometimes take about 3 months for the antibody to become positive. If you have someone with ongoing risk factors and you think they may have hepatitis C, it's best to check the RNA if you think they acquired it recently, if the antibody is negative, because the RNA will become positive first, usually within 7 to 12 days. So usually the antibody is enough to check. But again, the only time the antibody would be negative and someone has hepatitis C is if they just acquired it recently. So for the initial assessment, there's really not much to look at. Really, you look to see, does the patient have HIV? Does the patient have hepatitis B? None of these are deal breakers. If someone has hepatitis B, we just put them on treatment for that. But really, those are the only co-infections you look at. We screen women for pregnancy. These few studies that have occurred, the case studies where women were pregnant and didn't know it, they actually were fine. And so I think in the future, these medications may be approved for pregnancy, but during pregnancy, but not yet. And then you have to screen to see if they have cirrhosis or advanced fibrosis. Again, most of the time, this is not going to make a difference in your treatment, but anybody that has cirrhosis needs long-term monitoring for liver cancer. And honestly, the laboratory data that you need is minimal. The main thing you have to look out for is medication interactions, and statins are a common one that we'll talk about. So we used to show this slide all the time, and I had a colleague that spent 15 minutes talking about this slide. But we don't need to do that anymore because it's much simplified. So one of the medications that we use is called Mavorite. It's called glecaprevir preventasphere. It's 3 pills once a day for 8 weeks. The one medicine that you have to look out for is statins because patients can, for the most part, can't be on a statin with this medication. It can lead to rhabdomyolysis. And I think with most patients, they can be off of their statin probably for 8 weeks, but if not, you still have another regimen that we can use. Kidney function is not an issue anymore. It doesn't matter if they're on dialysis, it doesn't matter if they're CKD3, you can use these medicines. And the one group that you can't use this particular medicine is the patients who have decompensated cirrhosis. So your Child-Pugh B and C, the ones that may have ascites, and those are usually treated with the other regimen. So Mavorite works really well for most of your patients, even the ones that have cirrhosis that is well compensated. Second medication is Epclusa, which is sofosbuvir velpatasvir. This is 1 tablet a day for 12 weeks. This is, when you ask for, when patients have insurance or you're trying to understand which medicine they should be on, a lot of times the insurance company will tell you which medicine they approve. And most of the time, either one works. So Epclusa is a little bit longer. Instead of 8 weeks, it's 12 weeks, but it's 1 pill a day. And again, for both of these medicines, patients rarely have any side effects. I can't remember the last time anybody said anything about it. They really just take them like a vitamin and they do fine. This is the medicine that we use in patients that have ascites and jaundice and other more liver disease like Child-Pugh B or C. And the only thing with this medicine you have to be careful about is that the velpatasvir part of it needs acid in the stomach to be properly absorbed. So for patients who are on a PPI or H2 blocker, it's really just the timing. They can still be on it most of the time, but we have to make sure the timing is appropriate. And then this medicine, Vosevi, which is the Epclusa plus another voxilaprevir, this is only used for patients who have failed one of these newer drugs already before. So it's a very small group of people. And again, this medication, for the most part, is easy to take. And again, you won't be seeing that too often. So for most patients, you put them on the medicine and they don't really need labs during treatment, which again, with the interferon and ribavirin, it was sometimes twice a week labs because their hemoglobin was tanking, their platelets were dropping. But for the most part, these patients don't really need many labs, if any at all. The way that you know whether it worked or not is you check the RNA 3 months after their last pill. And if at that point it's negative, they're cured. And really, that's kind of it. If someone at the end of treatment has a normal ALT and they don't have cirrhosis, then you never have to really check anything. You don't have to check anything again. They don't need follow-up for their liver. The key is that some of the patients, especially with steatotic liver disease in the community right now, that when you treat the hepatitis C, it'll go to near normal. But if they still have some fat or steatosis in the liver, it may stay a little bit elevated. And then patients who have cirrhosis, regardless of if you treat their hepatitis C, they will still require lifelong monitoring for liver cancer because their risk is still there. Much lower once you treat the hepatitis C, but the risk of HCC is still there. So ECHO. ECHO stands for Extension for Community Healthcare Outcomes. So that man right there is Dr. Sanjeev Arora. And in the early 2000s, he was the only hepatologist in all of New Mexico. So if you were a patient who had hepatitis C in New Mexico, the wait to get into his clinic was about 6 months. And just the way that New Mexico is set up, many people would drive 4 or 5+ hours to get to Albuquerque. So what Dr. Aurora realized was that patients were getting to him too late, the ones that actually got to him. Many times they already had cirrhosis, they already had liver cancer. So what he did was he traveled throughout the state of New Mexico, and he went through and met with primary care physicians, nurse practitioners, even pharmacists, and recruited people who were interested in treating hepatitis C in their communities, in their clinic. And what he did was he set up a teleconferencing system where these providers would call in and they would present their patients, all de-identified, HIPAA compliant. I have a 52-year-old, these are his labs, this is RNA. And he would teach them how to treat their patients. And in those days, back with interferon and ribavirin. So a lot of people had their doubts. But in 2011, they published their findings in the New England Journal of Medicine. And what he showed was the patients that were treated by their primary care physicians and clinicians did just as well with regards to cure as the patients that drove down to New Mexico or down to Albuquerque to his clinic. Now, again, this was back in the days of interferon, which I can't express how much more difficult those drugs were. But you see back then, the cure rates were close to 60%. And the echo sites did just as well as the university clinic. So what he proved was there's no difference in the quality of care. These patients were getting cured just like they were in Albuquerque. But the best part is they were going to their primary care doc, the person that they feel most comfortable with, and they weren't having to spend all that money, all that gas to go to Albuquerque to get treated. And the reality of it is that a lot of patients, if they have to do that, they're not gonna get treated. They'll just say, never mind. And I can say that by working in the medical center. Every day, patients tell me how awful it is to drive down, how expensive the parking is, and they just feel more comfortable with their primary care. So it was good because he showed that the cure rates were the same, and there was also this sense of community among providers. So many times, and I can say this, so I worked in primary care for about 3 years after I finished my residency. And you just kind of, and I wasn't even working I was working in North Houston, but I did feel isolated because I was so used to this academic life, these lectures and grand rounds and having this community. And then I was stuck in a clinic all by myself and I felt kind of lonely, to be honest. But the great thing about this is that these providers have access to an academic center. They have specialists that they build a relationship with. And I'll be the first to say that the specialists learn more, like the same, if not more, from the primary care that are participating in this program. So the thought process behind Project ECHO is simple. Patients need access to specialty care, right? Not just people with insurance need specialty care, but sometimes they can't afford going to the specialist, or sometimes they just don't have access. And even if they did, there aren't enough specialists to treat everyone who needs care, especially in the rural and underserved communities. And I can't stress that enough. There's nobody really left with hepatitis C in my clinic. These are all patients who are going to their primary care, they're in the underserved communities, which just doesn't happen to be my clinic. But the idea behind ECHO is that it trains primary care clinicians to provide these specialty care services. And so in this case, he actually was a hepatologist and he started out with hepatitis C, but this is a global program. They have AIDS, they have autism, they have programs for autism, they have dermatology. There are hundreds of centers across the world, and there is an ECHO now almost for everything. But the idea is patients will get the right care in the right place at the right time. And this improves outcomes and reduces costs. So it used to be that when I showed this slide, everybody would say, oh, wow, this is really cool. But obviously once COVID happened, everybody is used to web conferencing, but this is really how it works. I'm the specialist, I'm at Baylor. People call in from all across the country, honestly, mostly Texas for our program, and they just present their patients. And not everybody is presenting. Some people are there just to learn. It's all de-identified, and we basically guide them in what kind of treatment they should use to treat their patients with hepatitis C. A lot of the people that we work with, again, they work in FQHCs, they work with patients who just got released from prison, they work with patients who are in Suboxone clinics. These are the people that we treat through ECHO. And so our program has actually been here for 10 years. And we've had about 2,800 case presentations. And honestly, we do all liver. I'll do whatever I can. Like I'll do hepatitis B, I'll do hepatitis C. Sometimes I have a PBC, which is primary biliary cholangitis. But we really just trying to help these patients that don't have access to specialty care. The majority of our patients that are presented do not have insurance, which again, are the people that need it, quite honestly. They're the ones that need it the most. But the good thing about hepatitis C is that if someone doesn't have insurance, we can actually get them treated for free because the pharmaceutical companies will give medicine free to patients who don't have insurance. The other thing is a lot of these patients are on Medicaid. Medicare is usually not as much of an issue to get approval, but Medicaid has really kind of softened on their restrictions. They used to say you had to have almost cirrhosis to get treatment approved. You had to have a negative drug screen. All that is gone. So now Medicaid does not ask for a drug screen. They don't ask for the patients to have advanced fibrosis before they'll approve this medication. So Medicaid is really not a hurdle anymore. It's just getting the patients that have Medicaid to get to someone who can treat their hepatitis C. So in summary, everyone in your clinic, all adults should be screened for hepatitis C because we have very good, effective treatment. And remember, about 50% of the people in the United States don't even know they have an infection. So it's really important to get out there and screen. Treatment has been simplified with the new medications. These medicines are very easy to, bless you. These medicines are very easy to use. I can't remember the last time I had a patient where I said, no, I don't have an option to treat them because they're easy to use, they're easy, there's not much monitoring, and the cure rates, if I didn't mention, are close to 100%. Treatment must focus on marginalized groups, so including injection drug users and ethnic minorities. And again, that's why I am really ecstatic about being here because this medical school, concentrates on those marginalized groups. And I really think these are the patients that we need to focus on, especially with the elimination efforts. And like I said, I've been saying it for 10, 11 years, but the primary care physicians, they are going to be our front line for eliminating hepatitis C. And that is my last slide. That's me, 1999, in front of Cullen. But I'm happy to take any questions.
Thank you so much. I had a couple of questions. One was when you were talking about instead of using the antibody, using the RNA. What is the significance of that? Because is there a timeline between when you find infection and the treatment has to be started?
No, so actually, I may have, for the most part, all of your patients should be screened with the antibody. But if you have a positive antibody, in order to confirm the diagnosis, you still have to check the viral load. So about 90% of patients with a positive antibody end up having a positive viral load, but there are about 10% that actually don't have hepatitis C. So for the most part, you always do the antibody first, and then the viral RNA gets checked next. And sometimes, if you're lucky, I don't even have reflex testing where I'm at. And so, but a lot of the clinics will have reflex testing where if the antibody is positive, it automatically goes to the RNA. What I was saying is that if you have somebody who says to you, I just did IV drugs 2 weeks ago, 3 weeks ago, maybe, in that case, the antibody, if they acquired hepatitis C with that instance, the antibody won't be positive. And so in that case, you would check an RNA as well, because it's not reliable.
And the other question was about, I know that it's not sexually transmitted if you are in a monogamous relationship,
Correct.
right? So when you're talking about screening someone who's in a monogamous relationship, once is enough. What about like when we are checking people who are high risk for STDs? For them, we do have to check HCV as well, right? Because the risk is increased if they have
Absolutely.
multiple.
So for people who have ongoing risk factors, we usually recommend annually, once a year, checking them for hepatitis C. And you're right. So in a monogamous relationship, the risk of acquiring hepatitis C from your partner is minimal. And again, the number they give is less than 5%. They should always be checked at least once, but in someone who has ongoing risk factors like IV drug use or for the most part, that's kind of the main one, or intranasal cocaine, that is another way it can be transmitted. Those patients you want to check annually.
Thank you.
Could I ask you about point of care testing? You mentioned that there are point of care tests that will check antibody and the RNA load, viral load. Did I understand that right?
Well, so that was my wish. Right now and I don't know if your clinics have reflex testing, where if the antibody is positive, it'll automatically check the RNA. But we currently in the United States, there's no point of care testing approved for hepatitis C. But I believe in Canada and some of the other countries, it is approved. It just hasn't made it to the United States yet because we have all these regulations about what can be improved and not with regards to testing. But yes, in Canada, which I believe has it, it's basically a test that within 30 minutes, you get the results for both antibody and RNA. And so in that case, it's similar to like for strep or when we were doing COVID back in the day, you can diagnose and essentially the patient could walk out with treatment the same day. So we don't have it approved in the United States as of yet, but part of President Biden's initiative is to get it approved, is to speed up that process because it would make such a big difference, less steps and less chances to lose patients along the way.
So I work and many of us do in low resource settings. We have a fair amount of hepatitis C where I practice. And if we could get that approved through pharmacy benefit, whatever's, do we not need to do any kind of imaging?
So not really. And you know, it's great if you can get an ultrasound. That's wonderful if they can afford it. But I'm telling you, a lot of the FQHCs that we work with, the patients can't afford it. It's expensive. They don't have insurance. So really, if you had seen me mention that FIB4, I can try to go back. FIB4 is just based on blood work, right? It's a couple of lab tests, AST, platelet age, that kind of stuff, and you plug it in, and it's pretty accurate. It can tell you, it's accurate kind of with the no cirrhosis or cirrhosis, and the gray zone is sort of in the middle. So with a FIB4, you can kind of pretty confidently say if somebody has cirrhosis or not. And again, if they have cirrhosis, but you can't tell by clinical exam, honestly, the treatment is unlikely to change. It's just that going forward, ideally, they should have monitoring for liver cancer or decompensation, like they should be followed. But most of the time, your treatment regimen won't change, even if they did have cirrhosis. So imaging is not necessary.
Great, thank you so much.
And you kind of learn, again, working with the FQHCs and clinics and patients that have limited resources, we learn to kind of eyeball the blood work and the clinical exam, and you can be pretty confident in the fibrosis that the patient has. And it doesn't really make much of a difference in most cases. So, you know, we used to have this long list of, even back then, 20 labs we would check, even with my FQHC patients, but now it's like 4, and that usually is good enough.
So I have a question not related to hepatitis C. I know you're a hepatologist. So for fatty liver, have you seen the benefit of statin, and is it in your usual practice to give them statins for it?
So when you look at the risk factors, and again, the nomenclature has changed to metabolic associated steatotic liver disease, MASLD, which I kind of agree with. I don't want anybody to tell me I have a fatty anything. So, But the risk factors for that are high blood pressure, high cholesterol, diabetes, and being overweight, specifically central obesity, right? So what I tell my patients is if their cholesterol is high, and these patients tend to have high triglycerides, then absolutely they should be on a statin because that is one of their risk factors. And many times I see that as their cholesterol improves, their transaminases improve as well. So if someone doesn't have an abnormal lipid panel, we don't necessarily put them on a statin just because we see steatosis on imaging. But if they have high cholesterol, like I said, triglycerides tend to be what our patients have, then absolutely they should be treated.
Thank you.
I have a question about the American Indian population. And I believe those were absolute, not relative numbers on the graph in terms of population. So I just wonder, in the strategic planning, a lot talks about marginalized populations, and this is a large marginalized group. What maybe from the Biden administration or in other sectors, what maybe is being done to target that population?
Yeah, so I can tell you with Dr. Aurora's, because he's originally from New Mexico, they started multiple echo programs in the American Indian population. So I remember we had sometimes people calling in from Oklahoma as well. So Echo has tried to increase care in those settings because, like I said, it's very, like they just don't have the care that they need. With the Biden administration, I don't know if that's included as one of the marginalized groups or underrepresented groups. I don't know specifically what, it's sort of like this broad-based program to provide more care to all of these groups. Like for the Suboxone patients, we've talked about having the Suboxone treaters treat hepatitis C, even if they're not primary care, because the patients are going to those clinics, or having telemedicine specialists phone into those clinics when the patient comes for another appointment there. And I think with the American Indian population, it would be kind of the same similar things as getting care, whether it's through telemedicine or in person into those communities. But I have to be honest, I don't know if there's any specific initiative for the American Indian in that program compared to the other marginalized groups.
I had a question. This was a really entertaining, captivating presentation. I stuck with it till I stuck with it till the end, which is very unique. So I got it all. So thank you for that. The part that you said, when you have these medications that have high cure rates, and if you have to give it to somebody with cirrhosis, is there any change in the cirrhosis that happens, or is it kind of constant and they're stuck with that cirrhosis?
Yeah, so it really depends on how far along they are. The good thing about when you treat hepatitis C in a patient who has cirrhosis is you automatically decrease their risk of liver cancer and you automatically decrease their risk of decompensation, meaning needing a liver transplant. So that in itself is huge. Most of the time, if somebody has cirrhosis and you can tell just by looking at their blood work, they've had it for a long time. And so you won't necessarily, hepatitis B, you can actually reverse the cirrhosis when they get treatment. But with hepatitis C, it's more of the best thing that you can hope for is pausing it and not making it worse. And if they have some decompensation, they actually can get better, which is wonderful as well. But for the long term, they will be treated as cirrhosis patients, especially because with the liver cancer, there are not necessarily any symptoms that occur. So the screening is important.
Are you aware of any studies or anything that's looking at reversing any of that cirrhosis?
So with C, no. With B, yes. I'm sure they're out there. I can probably even find it and send it to you. But right now with C, it's just kind of halting, making the synthetic function. So for liver, we look at something called the MELD score, which is how we determine where people are on the liver transplant list. So when you treat their hepatitis C, their MELD score improves, which basically means you're improving the function of their synthetic function. But Reversal of cirrhosis, I have not seen yet, but I would be the first to say it doesn't mean it's not there. But hepatitis B, you can go from stage 4, which is cirrhosis, to 2. It's remarkable, but that's for another day.
Sort of along those lines, in another area, have any medications come to market for hepatic steatosis and trying to reverse cirrhosis associated with that?
So there are so many ongoing trials right now for that specific thing. And the thing that's a little bit different than me is everybody in the liver world is all about steatosis, and because it is the new thing, right? I'm a little different in that I still like Hep C. I'm not as much interested in this only because I feel like, I'm going to answer your question, I promise, but I feel like this is tangible. I feel like in my lifetime, we could eradicate or eliminate eliminate hepatitis C. So I feel like this is really important work, which is why I focus so much on this. But everybody else is all into steatosis. And so there, a few years ago, there was a medication called obeticholic acid that came very close to getting approved. There's talks of a medication being approved later this year, but I can tell you the majority of the studies in hepatology right now are all about steatosis, reversing it, and even in patients with cirrhosis, different medications, infusions. And I believe by the end of the year, we have a good chance of something being approved for that.
Dr. Khaderi, we have an online question. Do we need patients to decline treatment? If so, why?
Do we need, I missed that one word.
Do you have any patients that decline treatment?
Oh, I've had like a couple, and most of them are scared. It used to be that they were scared because they heard about the old drugs, and the old drugs honestly were very scary. But usually once they hear about how easy the new medications are to treat and how they don't have side effects, they're almost always on board. So I don't get patients declining anymore. If anything, they decline because they're thinking of the old drugs, which doesn't happen too often anymore, or they're worried about cost. But all the patients that get approved for hepatitis C, the ones without insurance, it's free. The ones with insurance, it's almost always, it's not expensive. It's just a copay like their other medications. Anybody else?
Anything else? Anyone have any other questions online or in the room? One more question. Any issues with Medicaid coverage?
No, so not anymore. Before, right and left, they would decline for reasons, like I said, not enough scarring, their drug screen is positive. I don't like this, but now, a couple of years ago, there was some legislature that was passed, and so they no longer check there's no drug screen, there's no fibrosis score, so we can basically get everybody with Medicaid approved. They have their drug of choice, but almost always getting approval is not an issue. And so I guess I just want to say, if there are no more, I don't know if you can tell how passionate I am about this work. Really, and I am here because, honest to goodness, primary care, these are the people that are going to solve this problem. I worked for 3 years in primary care, and it was tough. Like, it was tough. I don't want to, it was great. It was tough, but you build these relationships with patients and you are their go-to person. They don't want to see me. They don't want to drive down to the med center. They want to be with who they feel most comfortable with. And so in the future, I hope this will all be a primary care treatment kind of a program, but I am here to help anybody that wants to learn. And I just want to say, there's no cost to any of this. The ECHO program is free. I do it. Nobody pays me. Nobody has to pay anything. But the more people I can reach, the more patients we can reach, the better, and the more successful this will be. Thank you.
Thank you for joining us today. If you didn't sign in, please sign in before you leave.